So now, we'll move to our last talk. Dr. Nair from Emory University of Atlanta would discuss the vascular access in AKI patients. Thank you so much.
Thank you. And thank you very much for the invitation, Dr. Mehta. This is my first time at AKI CRRT, and I'm just being blown away by the content, and I'm also learning a lot, and I hope I can share a little bit of what I know with you all here. And these are my disclosures, but just to start off with, I do want to emphasize that one size does not fit all, and I don't need to talk to this audience and tell them that there are many different kinds of AKI, and a patient who has no comorbidities with rhabdo is very different from a patient with multiple comorbidities who's got sepsis and AKI, who's very different from an AKI patient who has AKI on CKD. So we'll go with the premise of the talk that we are just going to talk about if there is no contraindication, what kind of access are we going to place in our patients when they need dialysis? So what do the experts say? So the KDIGO guidelines, these are outdated, and we are waiting for the update. But until then, I'll share the 2012 KDIGO guidelines that stated that if a patient with AKI needs renal replacement therapy, it should be via a non-tunneled dialysis catheter. But I do want to draw your attention to their disclaimer, where they said that clinicians still need guidance, and they knew the evidence was weak, but they decided to go ahead and provide at least some guidance, which should serve as a starting point. And then what about the KDOQI guidelines? They are for incident patients who are starting hemodialysis, and the recommendation is that everyone should start with a tunnel dialysis catheter, with non-tunnel dialysis catheters only being placed to limit infection risk in cases and for a short period of time, less than 2 weeks. So what do we see? What do we want to see in an ideal catheter? Well, let me first tell you the ideal catheter does not exist, but if we were to have one, what we would need is a catheter or an access that would provide high blood flow consistently and repeatedly. So you would want to have a good, large internal diameter, but you don't want to cause damage to the vein, so you want a small diameter on the outside. So basically the lining has to be thin. It has to be rigid enough to get over the guide wire, but especially in tunnel catheters, it has to be flexible enough so it can go through the subcutaneous tunnel. So we're asking a lot out of these ideal catheters, and we don't want them to have any complications, no thrombosis, no fibrin sheets. We want them to be biocompatible so that they do not set off the inflammatory or the coagulation pathways. So when we look at what are our expectations as nephrologists from our tunnel dialysis catheters, all we really want is the ability to provide a good dialysis for our patient. Good blood flow, no recirculation, and minimal short and long-term complications. So if the expectations are the same for both tunneled and non-tunneled catheters, then why is there a difference? And the main difference, as you can see on this slide right away, is the cuff that leads to the subcutaneous tunnel for the tunnel catheters. And over the years, I'm not going to talk to this audience about the catheter designs and the mechanics, but mechanics have evolved and catheters have become better over the years for the tunnel catheters. And this slide really just talks about all the differences that you can see, variable lengths, variable diameters between the two, with the tunnel catheters being slightly longer and slightly larger. Over the years, materials have changed, so both of these catheters are primarily either polyurethane or silicone. And the big difference is the tip placement. Because the catheters are longer when they are tunneled, the tip placement is ideally in the mid-right atrium as compared to the SVC and the right atrial junction in the non-tunnel catheters. And because of this, we do require some procedural limitations. You can't put these at the bedside as compared to the non-tunnel catheters. And the complications, of course, are related to the procedure itself in the tunnel catheters, and more in the short term with infections, mechanical dysfunctions, and dislodgement in the non-tunnel catheters. So let's talk a little bit about the evidence. So we are going to move up the evidence pyramid. So we have a retrospective study, a prospective cohort study, and a randomized trial that I'll discuss. So in this retrospective study, there were, I'm going to go back just a second. There were 76 patients who received a tunnel dialysis catheters for AKI. And of these, we've been talking about 1 week or 2 weeks for non-tunnel catheters. They found that the mean dialysis time was 34 days. And only 20% of these patients recovered within the first week. And so the authors supported initial tunnel dialysis catheter placements. Now, this is another prospective cohort study where they had 154 patients that that received either a tunnel dialysis catheter or a non-tunnel dialysis catheter, and they found that there was improved delivery of dialysis as well as fewer mechanical complications. And these authors also recommended that we start off with a tunnel dialysis catheter for an AKI. And you can see here the ratio of interruptions, this is the non-tunnel catheters and the tunnel catheters, was much higher for non-tunneled. The blood flow was much lower for the non-tunneled. And then the mechanical complications also were much higher for the non-tunnel catheters. And then we have a randomized control study that actually looked at 100 patients where they randomized. These were silicone non-tunnel catheters, but based on the length, because the issue with the length is the risk of causing atrial arrhythmias or, in some cases, atrial perforations. And they just randomized them based on their length. And as you can see, the catheters that were longer did much better. They had improved dialyzer lifespan, improved dialysis dose, reduced number of dialyzers clotted, reduced number of circuits, and they were able to show individual cost reduction if you were to take into account all the wastage that happened when the circuit clotted, that there was a significant amount of cost reduction. And if you add these, on top of that, the cost of a secondary procedure, if these patients were to get a tunnel catheter, that just adds to the cost of the system. So what about the flip side? Can we use non-tunnel dialysis catheters for incident ESKD? And the answer is yes, definitely in resource-limited situations, but also just our neighbors in Canada looked at a 10-year registry where they had over 20,000 patients who started dialysis with a catheter, and half of these patients started with a non-tunnel catheter. And unfortunately, we saw this even if the patients had seen a nephrologist for 12 months prior to the initiation of their first dialysis treatment. And of course, this varied based on the geography as well, but you can see a large number of them starting with non-tunnel catheters. And the authors wrote in the paper, initiation of chronic dialysis with a non-tunnel dialysis catheter is even worse than a suboptimal start. It is least optimal. So those are very strong words. And if we all know and if we all understand that tunnel dialysis catheters do provide us with better care for our patients and better dialysis, then why are we starting with non-tunnel dialysis catheters, and how do we bridge that practice gap? So what are the barriers that we are talking about? A couple of these we have already addressed, including the cost, and it's not just the material costs, but the non-material cost to the patient as well, and their morbidity. And then the duration of therapy, I showed you one study where they saw that the mean duration of dialysis was 34 days. And as you can see, this is consistent in other studies as well. So it really boils down to one thing, the procedure itself. So where are we doing these procedures? Who is doing these procedures? And how is this leading to the potential treatment delays? And so I think at this point, we really do need to challenge the status quo. And we have precedent for that. If you think about the field of interventional nephrology, it started off because just a few people refused to accept the status quo. And here you can see that instead of doing it under fluoroscopy, can you do these tunnel catheters at the bedside using ultrasound? And this is the visual abstract of this prospective study. And here you can see 134 catheters that were placed at the bedside using ultrasound guidance, a two-operator technique. And you can see excellent primary success rate as well as functionality. But what this visual abstract really doesn't show is the complications. So out of 134 patients, 2 patients died in less than 48 hours. They could not attribute it to the procedure, but there was no other reason as well, except they labeled it as pulmonary embolism and aspiration pneumonia. 2 patients had hemoglobin drops of more than 2 grams requiring transfusions, and there were 8 arterial punctures. And I will just quote, I was at dinner last night, and Professor Louis Forney made this statement that I think applies very well to this study. You can't just have change for change's sake. Any change has to result in an improvement. So we are not there yet, but I do think that might be the future. But then we have to think about really thinking outside the box. And the COVID pandemic has really brought together a lot of creativity, a lot of innovation. And I think we do need to think outside the box and see what we can do better. And how about changing who places these catheters? I know it's a little controversial, and I will admit I'm slightly biased towards that. But what if the interventional nephrologists were putting these catheters in? And here is a study that has actually looked at the difference between interventional radiologists and interventional nephrologists doing these procedures. The time from deciding that you were going to start dialysis to placing the tunnel catheters, in red is the radiologist, in gray is the nephrologist, and actually initiating dialysis. As you can see, the times are much shortened when it is a nephrologist who's doing these procedures. And so I will say now, I think I've given you enough evidence to suggest that tunnel dialysis catheters in patients who have no contraindications might be the right way to go. But I still firmly believe, having put in hundreds of tunnel dialysis catheters and even more non-tunnel dialysis catheters, that these procedures should be done carefully and should be done, if possible, under fluoroscopy as of now until we improve ultrasound guidance. And we have to, if we are ever confused about something, think about the patient. Keep the patient as the true north. If this is something that we wouldn't do to ourselves, we shouldn't be offering it to our patients. So it should be done, but perhaps it's a system issue that we need to change, a process issue that we need to work towards so that we can always provide the right care for the right patient at the right time for the right reasons. And I will say that if we are able to minimize the waste when we put in tunnel dialysis catheters instead of non-tunnel dialysis catheters, perhaps we can get to the elusive part of the green nephrology that everybody was talking about yesterday. And I do have to thank Marlise and Claudio for this short video. Critical care nephrology, go green. And until the KDIGO guideline comes out, I do think that we have to continuously try to work together to change and to see if we can actually move the system processes in the right direction. And the world is watching for the next KDIGO guidelines. Thank you so much.